Welcome everybody to the audio-vestibular audio-vestibular medicine case discussion group. We are here and have a special guest lecture. We got a little household stuff to take care of first. Number one, we present monthly and do interesting cases in audio-vestibular medicine. Our hosts, myself, Gerard Gianoli, Mohamed, Hamid, and Eugen Ionescu, are the regulars, but everybody's encouraged to come. Information discussed is meant solely for educational purposes and not intended as medical advice for any individual. For individual medical advice, please seek the counsel of your own physician. While these conferences are geared toward medical professionals, patients are welcome. However, we will not discuss individual patient cases in this setting. Please speak to your own physician for individualized medical care. And lastly, we will archive all of our discussions at our YouTube website, which is at AVM Case Discussions. As I mentioned, today we're honored to have a special guest, Professor Leonardo Manzari, who is going to talk to us about vestibular memory from velocity storage to persistent dizziness and clinical phenotypes. And welcome, Leonardo, and we're all looking forward to this lecture. I'm very excited for
it. Thank you for the invitation, Gerard. Thank you all. We are ready. Good evening, all of you. And first of all, today I would like to discuss a simple but clinical challenging question. How does the vestibular system keep motion alive long enough to guide behavior? And what happens when this memory is either too weak or too persistent? The title says that vestibular memory, the core, is temporal organization of motion. And now, before beginning, I would like to express my sincere gratitude to Gerard Gianoli for inviting me to take part in this audio-vestibular medicine case discussion. Gerard, thank you not only for the invitation, but also for creating this remarkable space where clinical experience, physiology, and open scientific discussion can meet. I would like also to thank Mohamed, Hamid, and Eugen Ionescu. It is always a pleasure and privilege to share ideas with colleagues whose experience, curiosity, and friendship have contributed so much to our field. Well, this photograph was taken in Paris during the World Congress of Audiology meeting in 2024, and for me, it captures something very important. Science is built not only through papers and laboratories, but also through conversation, friendship, and shared intellectual journeys. So, Gerard, Mohamed, Eugen, thank you very much. I'm truly delighted to be with you this evening. And now let us begin our journey, not in a clinic, but in a Abbey, near Paris. Near Paris. The Abbey is Rougemont. This story begins not in a clinic, as I say, but in a Abbey, Rougemont, near Paris, July 1977. In that place, some of the most important ideas on gaze control, vestibular nuclei, optokinetic nystagmus, and vestibular modeling were discussed. Among them, one idea would become central for the next 50 years. The name of this idea was velocity storage. Velocity storage was born as a physiological concept, a way to explain why the eyes continue to move after the stimulus has changed, or even disappeared. It was a model of eye movement, of optokinetic nystagmus, after optokinetic after nystagmus, and vestibular nystagmus. But today, almost 50 years later, I would like to bring that idea from the habit back to the patient. Because in daily practice, we often meet patients whose fast vestibular pathway seems almost normal, but who still feel unstable, visually dependent, disoriented, or persistently dizzy. In this patient, the question is no longer only what is the gain of the VOR? The deeper question becomes what has happened to the brain sustained estimate of motion. This is where velocity storage returns to the clinic. From Rogemont to the patient, velocity storage as the hidden language of sustained vestibular dysfunction. After Rogemont, there is a book, a red book, Control of Gaze by Brainstem Neurons, edited by Robert Beckett and Alain Berthoz, published in 1977. This was not just a collection of proceedings. It was one of those books in which a field begins to organize its own language. Brainstem neurons, vestibular nuclei, optokinetic nystagmus, vestibular nystagmus, visual-vestibular interaction, modeling, all these ideas were placed together inside the same scientific space. And inside this book, two contributions became particularly important for the story I want to tell today. One was the paper by Raffan and Cohen and Matsuo on a velocity storage mechanism responsible for optokinetic nystagmus, optokinetic after nystagmus, and vestibular nystagmus. The other was the David Robinson chapter on vestibular and optokinetic symbiosis and on the power of modeling to explain oculomotor physiology. In that book, velocity storage was not yet a clinical tool. It was a physiological model, a way to understand how visual, vestibular signals could be organized, combined, and coordinated. Nearly 50 years later, I believe that the same idea can help us understand our patient. Not only their eye movement, but their persistent instability, their visual dependence, and their sustained vestibular dysfunction. The Red Book gave velocity storage its physiological language. Today, we will try to give it a clinical voice. Inside that Red Book, three names stand at the foundation of the story I won't tell today. Theodore Raffan, Bernard Cohen, David Robinson. Raffan, with his mathematical vision, helped transform velocity storage into a model of visual vestibular interaction, spatial orientation, and sustained vestibular dynamics. Bernard Cohen brought the power of clinical neurophysiology to the study of eye movement, vestibular nuclei, optokinetic nystagmus, optokinetic after nystagmus, and vestibular nystagmus. And David Robinson showed us that modeling is not an abstract exercise. It is a way to explain physiology, a way to ask whether a hypothesis can predict what the nervous system actually does. Together, they transform nystagmus from a clinical observation into a model of the vestibular brain. And this is the crucial point. They were not simply studying eye movement. They were studying how the brain estimates motion, how the brain combines vestibular signals, visual signals, and above all, time. Time. This is why their work is still alive today, because every day in the clinic, we meet patients whose symptoms cannot be explained only by the fast vestibular ocular reflex. In these patients, we need to go back to that foundation triangle. We need to ask not only how the eye moves, but how the brain stores, updates, and interprets motion over time. From Raffan, Cohen, and Robinson, we inherit not only a model of nystagmus, but a model of the vestibular brain. Nearly 50 years later, the question has changed. In 1977, the question was why does the eye keep moving? Today, in 2026, the clinical question is why does the patient keep feeling unstable? Why does the patient still feel dizzy, disoriented, visually dependent, or insecure while walking, even when the fast vestibular tests appear almost normal? This is a question we face every day in clinical neurotology. Sometimes the vehicle is perfect, is preserved. The high frequency VOR is not frankly impaired. The classical sign of an acute vestibular loss have disappeared. But, and yet, the patient is not well. The patient still feels motion, still feels imbalance, still feels uncertainty in space. So perhaps we are not only dealing with a problem of reflex gain. Perhaps we are dealing with a problem of temporal integration, a problem of visual vestibular weighting, a problem of autolytic and gravitational reference, a problem of the brain's sustained estimate of motion. This is where velocity storage becomes clinically important, because velocity storage is not only about how long nystagmus lasts, it's about how the vestibular brain stores, updates, or fails to update motion over time. So the journey from 1977 to 2026 is also a journey from the moving eye to the unstable patient, from physiology to clinical interpretation, from eye velocity to perceived instability, from a model of nystagmus to a window into sustained vestibular dysfunction. The eye reveals the mechanism, the patient reveals its clinical meaning. So, what do we actually mean by vestibular memory? I am not referring to autobiographical memory or to conscious recollection. I'm using the word memory in a physiological sense, the persistence of a motion estimate within the nervous system. The semicircular canal provides relatively brief signals. The brain then extends that signal in time, integrate it in visual information, align it with gravity, and continuously update the estimate of self-motion in space. In other words, vestibular memory is a distributed neural operation that decides how long a motion signal should remain available. It must persist long enough to guide the eye movement, the posture, orientation, and behavior, but it must not persist for too long. Otherwise, the internal estimate of motion may outlive the event that generated it. And the opposite problem is also possible. The estimate may decay too early, before the brain has adequately represented the ongoing motion. So, the essential point is not simply whether motion is detected. The essential point is whether motion is stored for the correct amount of time, correctly integrated with vision and gravity, and appropriately extinguished when it's no longer usable. This temporal regulation is what I mean by vestibular memory. And this is immediately raise the next question. Why is such a storage necessary in the first place? Why is storage necessary? Because the peripheral canal signals is relatively brief. At the rotation, deflect the cupula and generates a canal response. But that response decays within a few seconds. However, eye movements, perception, and spatial orientation often need to persist longer than the peripheral mechanism alone would allow. So the brain creates a central motion estimate that outlasts the immediate canal signal. This is the essential role of vestibular of velocity storage. It bridges the temporal gap between a short-lived peripheral input and a longer-lasting behavioral requirement. But storage is not only about duration. The central estimate is also shaped by autolytic and visual information, and its axis is continuously referenced to gravity. In other words, the canal tells the brain that rotation has occurred. Velocity storage helps determine how long that motion estimate should remain available and how it should be oriented in space. So, the key message is very simple. The peripheral signal is short, but the useful estimate of motion must last longer. And to understand how the brain achieves this, we need to distinguish two temporal pathways: a fast direct pathways and a slower indirect pathways. This is where David Robinson model become essential. Robinson formalized a very important idea. The vestibular response cannot be explained by a single pathway. There is a fast pathway and there is a slower pathway. The fast pathway is the direct pathway. It responds rapidly to changes in head velocity. It is a high pass transient and essential for immediate gaze stabilization. But this fast pathway does not explain the persistence of high velocity after the stimulus has changed or stopped. For that, a second pathway is required. The indirect pathway, a pathway with leaky integration. This pathway stores velocity for a limited time, prolongs the response, and generates after responses, such as the optokinetic after nystagmus, or what we see every day in the clinic, a post-rotatory nystagmus. So, Robinson model gave us a dual architecture, a direct pathway for fast gaze stabilization and an indirect pathway for sustained vestibular dynamics. The distinction is not only historical, it is clinical crucial, because when we perform a video head impulse test, we are mainly interrogating the fast, direct, high-frequency pathway. But when we study rotatory responses, optokinetic nystagmus, optokinetic after nystagmus, or post-rotatory nystagmus, we begin to interrogate the slower, indirect velocity storage pathway. This dual architecture is the physiological basis for the clinical distinction. I will develop later fast and transient versus slow and sustained vestibular domains. Robinson model gave us the map, one vestibular system, two temporal languages. The classical model described the velocity storage as a leaky integrator. This word, leaky, is very important. The system stores velocity, but not forever. It allows persistence, but also decay. It remembers motion, but it can also forget it. And this is essential, because a vestibular system that never forgets motion would become unstable. Without leakage, the system would accumulate low-frequency noise, drift, and inappropriate motion signals. With leakage, the stored velocity state can gradually return toward the baseline. New sensory information can update the system. Visual fixation, head tilt, contact cues, and gravity-related information can modify or suppress the stored response. So, the leak is not a failure of the system. It is a physiological design feature. It prevents drift, it allows updating, it keeps the vestibular estimate flexible. Velocity storage is the spore, not a rigid memory of motion. It is a dynamic estimate that can be stored, released, reweighted, or dumped according to constant. This is why the leak integrator is one of the most elegant ideas in vestibular physiology. The vestibular brain must remember motion, but it must also know when to let it go. Velocity storage is often introduced as a mechanism that simply prolongs the vestibular response, but that definition is too narrow. Its first function is certainly duration. It extends canal-related responses beyond the short mechanical dynamic of the peripheral labyrinth. But at the same time, it performs multisensory integration. It combines canal information with otolytic and visual signals so that motion is not interpreted in isolation. It also contributes to spatial alignment. The stored estimate must be continuously reoriented relative to the gravity, because the same angular motion has a different meaning depending on the head position and the spatial context. And finally, velocity storage is state-dependent. Its behavior is modulated by cerebellum, by alertness, by visual fixation, and by the constant in which motion occurs. So, velocity storage is not simply a longer time constant. It's a dynamic, gravity-referenced, multisensory estimate of motion over time. It regulates not only how long the signal persists, but also how that signal is interpreted, aligned, and updated. This broader view is essential in clinical daily practice because a patient may have preserved rapid canal responses and still show abnormal integration, spatial orientation, or sustained motion processing. And this is possible because velocity storage is not located in one single structure. It emerged from a distributed brainstem cerebellar network. Velocity storage should not be imagined as a single anatomical box. It emerges from a distributed brainstem cerebellar network. The semicircular canals provide the initial angular motion signal. That signal enters the vestibular nuclei and their commissural connection, where it can be prolonged, compared across the two sides, and transformed into a central estimate of velocity. From this network, one major output reached the ocular motor system, generating the eye movement that we can measure clinically as vestibular or optokinetic responses. But there is also another essential branch. Through the nodulus and uvula, these two cerebellar structures, the stored signal is referent to gravity, and its spatial axis is continuously recalibrated. This contributes not only to eye movements, but also to the perceptual and postural estimate of self-motion. So, the final behavior output is broader than nystagmus. It includes gaze stability, spatial orientation, posture, motion perception, and the patient's subjective sense of stability. This is why I prefer to describe velocity storage as a distributed integrator rather than a single reflex mechanism. The same network that produced measurable ocular response also contribute to how the patient experience motion and maintain balance in daily life. And this distinction is clinically important. The oculomotor output might appear relatively preserved, while perceptual or postural integration remains abnormal. This distributed organization also explains why different vestibular tests interrogate different temporal components of the same system. This slide summarizes the central framework of the presentation. Vestibular tests are not interchangeable because they interrogate different temporal operating modes of the same system. On the left is the impulsive domain. These are very brief, eye jerk responses occurring over milliseconds. Bedside head impulse test, video head impulse test, head impulse, and SHIMP primarily test rapid canal-driven gaze stabilization. They tell us whether the fast vestibular pathway can react immediately to a sudden head movement. In the middle is the phase-locked domain. Oh, I love it. Here, the responses remain tightly bound to the stimulus. C-vamp, O-vamp, and SWIN are generated by sound or vibration and provide short latency, synchronized responses. They are not sustained estimate of motion. They are stimulus-bound readout of a specific vestibular pathway. On the right is the time-integrated domain. This domain operates over seconds and minutes, rotatory chair testing, calorics, head shaking responses, optokinetic and optokinetic after nystagmus, visually enhanced VOR, and suppression of the VOR, all asked whether motion can be integrated, maintained, reweighted, and finally extinguished over time. This is the domain in which velocity storage becomes especially important. The key points is that these categories are functional and temporal, not rigid anatomical compartments. There is overlap between them, but clinically, the distinction is extremely useful. A patient may have a normal impulsive responses and still have a profound abnormality in the time-integrated domain. So, when different tests disagree, that disagreement may not be noise. It may be the physiological signal we are looking for. And this leads directly to one of the most important diagnostic blind spots in modern vestibular medicine. A normal V-hit does not necessarily mean a normal vestibular system. This is one of the most important diagnostic blind spots in contemporary vestibular medicine. A normal V-hit is extremely valuable information. It tells us that the rapid eye acceleration, canal-driven vestibular ocular response is functioning adequately. But it does not tell us that the entire vestibular system is normal. The V-hit mainly interrogate the fast road. I love to name this fast road the motorway. It tells us whether traffic can move rapidly during a brief head impulse. But the motorway may be open while the older road, the slower, sustained route, is failing to regulate traffic over time. In my region, in Italy, I often use the image of the motorway from Cassino to Rome and the Casilina, the same older road from Cassino to Rome. The motorway may be perfectly open, while the Casilina is congested, poorly regulated, or unable to carry the longer journey. In the same way, a patient may show a normal V-hit and still have abnormal, prolonged integration, impaired visual vestibular persistence, defective gravitational reorientation, or difficulty terminating a motion estimate. So the problem is not that V-hit isn't sufficient. The problem is stopping our reasoning at V-hit. And normal fast responses should not close the case. It should open the next question. What happens when the vestibular system is asked to represent motion over seconds rather than milliseconds? That is where the sustained domain becomes clinically visible. And one of the papers that helped me rethink this distinction was the 2025 hypothesis paper on swing, velocity storage, and self-stability from Ian Courtois, David Z, George Dumas, Christopher Patras, and Julia Drugaski. Now we move from the classical model to the modern view. In the classical model, vestibular velocity storage was mainly described as a mechanism that prolongs canal dynamics, but is only the beginning of the story. Last year, in February, Ian Courtois and colleagues published an hypothesis paper that was very important for me. The title was Skull Vibration-Induced Nystagmus, Velocity Storage, and Self-Stability. This paper made a crucial connection. it linked skull vibration-induced nystagmus, also called SWIN, with the direct pathway, the indirect pathway, velocity storage, and the sensation of cell stability. The hypothesis was elegant. Vibration selectively activates primary vestibular afferent with irregular resting discharge. This irregular afferent mainly project through the fast direct pathway. They can generate a rapid nystagmus as in SWIN, but they might bypass or only weakly engage the indirect pathway and the velocity storage in the integrator. This is why SWIN often begins abruptly, is maintaining during vibration and stops abruptly when the vibration stops, with little or no after nystagmus. And this point is fundamental because after nystagmus is one of the clinical signs that velocity storage system has been loaded. So, SWIN is not only a vibration-induced eye movement. It becomes a clinical probe, a probe of how transient vestibular input interact or fail to interact with velocity storage and self-stability. For me, this paper reopened velocity storage as a clinical question. Not only where does the nystagmus beat, but also which vestibular pathway has been activated, the fast direct pathway or the slower indirect sustained pathway of velocity storage. And from this point, a new clinical question emerged. Can SWIN help us understand the dissociation between fast vestibular activation and sustained vestibular instability? This was the bridge from vibration to self-stability, and it prepared the next step of my clinical interpretation. The 2025 hypothesis paper reopened velocity storage as a clinical question, not only how the eye moves, but how the vestibular brain maintains self-stability. Up to this point, we have described vestibular memory as the regulated persistence of a motion estimate. But clinically, this regulation can fail in two opposite directions. On the left is insufficient storage. Here, the motion estimate decays too early. Post-rotatory responses are abnormally short. Sustained VOR or optokinetic responses are weak, and the brain is unable to maintain a useful representation of motion over time. The patient may still detect that motion has started, but the internal estimate is not adequately sustained. This is the pole illustrated by a low storage velocity storage dysfunction phenotype. On the right is maladaptive persistence. Here, the opposite happens. The motion estimate outlives the event that generated. The patient may continue to feel sway, rocking, internal motion, or visual dependence after physical motion has ended. This might provide a mechanistic bridge to some persistent dizziness phenotype, including PPPD or Malda-Bachmann syndrome-like states, while remaining distinct from their formal diagnostic criteria. The key point is that these are not simply case or less or more vestibular function. They are both disorder of temporal regulation. In one case, the system forgets motion too early. In the other, it cannot forget motion when it should. So the clinically relevant question is not only whether motion is detected, it is whether the motion estimate is stored from the correct amount of time. And now I would like to show you a real patient who illustrates the first pole, insufficient storage. This slide protects the logic of the talk. D'Alesio is the name of the patient, does not show failure to forget. It shows the opposite problem, failure to store. Let me now introduce the clinical case that illustrates the insufficient storage pole of vestibular memory dysfunction. This is a 70-year-old man with recurrent episodes of severe disequilibrium. At the time of evaluation, however, the usual clinical signs were largely absent. There was no spontaneous nystagmus, no positional nystagmus, and the head shaking test was essentially negative. Hearing were substantially preserved, and the bedside examination did not reveal a major acute vestibular deficit. So, at the first sight, this looked like a relatively reassuring examination, but the patient was clearly symptomatic. This creates the clinical puzzle. What happened when the same vestibular system is tested not only over milliseconds with rapid impulses, but over seconds with sustained stimulation? In other words, could normal fast responses conceal a profound failure of temporal integration? That is exactly what happened in this patient. His rapid vestibular pathway appeared preserved, but the sustained domain told a completely different story. Let us first look at the fast domain. Now, let us look at the fast domain. On the left, the 6th canal V-hit shows gain that are globally preserved, close to 1 across all canal planes. There is no coherent pattern of a major canal deficit, and the asymmetries remain limited. On the right, the lateral shim is also preserved, with gains of approx 0.92 on the left and 0.95 on the right. The expected anticompensatory saccades are present, confirming that the rapid vestibular drive remains available. So, in the impulsive domain, this vestibular system works remarkably well. Brief acceleration and impulses are detected, and the high respond appropriately. In other words, the motorway is open. If we had stopped here, we might have concluded that this patient had no relevant vestibular dysfunction, but that conclusion would have been incomplete. These tests tell us what happened over milliseconds. They do not tell us whether the same system can maintain a reliable estimate of motion over seconds. And when we move from the fast domain to sustained stimulation, the picture changes dramatically. Let us now look at what happens when motion must be integrated and sustained over time. Now, the hidden abnormality become visible. When we move from brief high acceleration impulses to sustained stimulation, the responses changes dramatically. On the left, the optokinetic response is clearly reduced. The gain is approx 0.35 in the leftward direction and 0.23 in the rightward direction. So, visual motion integration is not only weak, but also somewhat asymmetric. On the right, the sinusoidal chair test is even more striking. At 0.22 Hz, the gain is only 0.10. The chair is moving with a large and regular sinusoidal waveform, but the ocular responses remains almost flat. This is the key dissociation. During brave head impulses, the vestibular system responds appropriately, but when motion must be maintained and integrated over several seconds, the response nearly disappears. So the problem is not primarily the detection of motion onset. The problem is the failure to sustain an adequate internal estimate of motion over time. This is why I describe the sustained domain as collapsing. The fast wave pathways is available, but the time-integrated network is profoundly hyporesponsive. And the clearest expression of this failure appear in the post-rotatory response, where the time constant is reduced to approx just 1 second. This is probably the most striking finding in the entire case. During the multi-turn test, the post-rotatory time constant is approx 1 second in both directions. In other words, when the chair stops, the ocular responses ends almost immediately. The peripheral detector has reacted. The motion has been sensed, but the central network fails to prolong and maintain the motion estimate. This is not simply a low amplitude response. It's a near complete failure of temporal persistence. The stored states decays almost as soon as the external rotation ends. And this is exactly what we would expect in a low storage phenotype. The system can detect motion onset, but it cannot preserve the internal estimate for the duration normally required by behavior. So here, the problem is not failure to forget motion. It's the opposite. The brain forgets motion too early. This 1 second time constant is therefore the clearest physiological expression of the transient sustained dissociation in this patient. When we place all these findings together, preserved Vihit and Shimp, weak optokinetic nystagmus, sinusoidal gain of 0.1 and a 1 second time constant, the phenotype become very clear. When we place all these findings together, the pattern became very clearly. The Vihit is essentially normal, Shimp are preserved, so the patient can detect brief acceleration, but the sustained measure tell us a completely different story. As a consequence, the internal representation of movement become weak and unreliable. This is why I describe the case as a low storage velocity storage dysfunction phenotype. I use the word phenotype deliberately. I'm not proposing a fully validated diagnostic category, and I'm not assigning the dysfunction to one single anatomical structure. I am describing a reproducible physiological pattern, preserved rapid vestibular responses associated with profound impairment during sustained and time-integrated stimulation. The same vestibular system, therefore, appears almost normal when interrogated over milliseconds, and profoundly abnormal when asked to represent motion over second. The patient does not fail to detect motion. He fails to maintain an adequate estimate of motion over time. And this point is essential for the logic of the webinar. This is not a failure to forget phenotype. It is the opposite pole. This patient forgets motion too early. This patient therefore represents one temporal phenotype. The same regulatory system can fail in other ways, by storing motion too much, asymmetrically, or by failing to disengage after the event has ended. This patient also shows us other things. More broadly, the same vestibular memory system can fail in several different ways. The first is reduced storage. Here, the motion estimate decays too early. The second is excessive storage. Here, the estimate persists for too long. The patient may experience prolonged after effect, visual motion, intolerance, and increased susceptibility to motion sickness. The third is asymmetric storage. In this case, the problem is not simply duration, but direction. We may see head shaking asymmetry, post-rotatory bias, or evidence of incomplete compensation after an old unilateral lesion. And the fourth is the maladaptive persistence. Here, the system fails to disengage. Motion outlives the event, and the patient may continue to experience internal sway, rocking, or visual dependence after the physical stimulus has ended. So, the core message is that pathological vestibular memory is not only too much memory, it may also be too little, too asymmetric, or poorly extinguished. These temporal phenotypes do not map one-to-one onto a single clinical diagnosis. Abnormal temporal integration may contribute to several different syndrome and symptom patterns. It might be present in patients with persistent disequilibrium after vestibular neuritis, especially when the acute static signs have resolved, but dynamic compensation remain incomplete. It may contribute to visual vertigo or motion sensitivity, where the patient becomes unstable in traffic, in supermarkets, crowds, or other visually complex environments. It might also be relevant in some PPPD phenotypes, particularly when visual dependence and persistent motion sensitivity dominate. Malde-Debarkman syndrome-like states provide another example in which rocking or swaying may persist after the original motion environment has ended. And in other patients, the most appropriate description may simply be a velocity storage dysfunction phenotype defined by a clear temporal dissociation across vestibular tests. But I want to be very cautious here. I'm not saying that abnormal velocity storage causes all this syndrome. I am saying that abnormal temporal integration may be one contributing mechanism across several clinically distinct phenotypes. Therefore, no syndrome should be reduced to one mechanism, and no abnormal test should replace established diagnostic criteria. The value of this framework is not to create a universal diagnosis. It is to identify a physiological dimension that may help us understand why different patients experience persistent instability in different ways. This is especially important when we discuss about PPPD and Mulder-Barkman syndrome because they may share some temporal feature while remain diagnostically distinct. PPPD and Mulder-Barkman syndrome may share some features of persistent motion sensitivity, but they must remain clinically and diagnostically distinct. On the left, PPPD is defined by the established Pyrenees Society criteria, and symptoms are present on most days for at least 3 months and are typically exacerbated by upright posture, active or passive motion, and moving or visually complex environment. Velocity storage might help us investigate persistent visual dependence and abnormal temporal integration in some PPPD phenotypes, but it does not diagnose PPPD. It does not replace the formal diagnostic criteria. On the right, Mulder-Barkman syndrome is characterized by rocking, bobbing, swaying, usually after passive motion exposure. A particularly interesting feature is that the symptoms may temporarily improve when the patient is re-exposed to motion. This makes the syndrome a natural clinical model of a persistent motion estimate or maladaptive readaptation. But Mulder-Barkman syndrome must remain distinct from PPPD and from other chronic dizziness syndrome. So the caution is essential. One temporal mechanism may contribute to several syndromes, but no syndrome should be reduced to one mechanism. The purpose of the velocity storage framework is not to collapse diagnosis together. Is to identify a physiological dimension that make up across them. How motion is stored, maintained, reweighted, and extinguished over time. This brings us to the practical clinical question: how should we examine a patient if we want to distinguish motion detection, transmission, integration, and disengagement? So this slide summarizes the practical logic of a multi-domain vestibular examination. The examination should answer a physiological question, not merely produce a battery of numbers. This is the practical structure in the Cassino clinic that I use every day. Bedside, in raised position to watch the spontaneous nystagmus, head shaking test, positional test, and test of skew, such as the bucket test. After we test the transient system with video and impulse test, head impulse test, and suppression of the VOR in the IMP paradigm. After we use the phase locked test, such as skull vibration-induced nystagmus, cervical vamp, and ocular vamp, and then we we test the sustained vestibular system, testing calorics, rotatory chair, and see what happens with optokinetic stimulation and when we perform visually enhanced VOR or suppression of the VOR. In the context, we use also visual trigger, audiometry, and ecological motion history. What each test contribute? Be hit and shape. The primary question for us is rapid canal drive preserved? And you can see the temporal domain. This is the impulsive temporal domain. When we move to the phase-locked pathway, the question is, are phase-locked pathway symmetric or asymmetric? And we are investigating the temporal domain named phase-locked. When we perform the other test, we are testing the sustained pathway, the integrated pathway. So, when we perform head-shaking test, rotatory chair, or calorics, does the asymmetry emerge over time? The question. With optokinetic stimulus, can visual motion enter and persist in storage? And in the case of VOR, BVOR, and boards, can visual vestibular interaction remain stable? This is crucial for our technician, and when we recommend for the patient the rehabilitation therapy. And this is the question. This was the question, and after the answer, we can cooperate with our physiotherapist, talking about rehabilitation that is perfect for our patient. So some patients need to relearn not only how to tolerate motion, but also how to stop representing motion when the stimulus ends. For this reason, start, stop transition, and motion termination may be important therapeutic targets. Then come ecological transfer. Rehabilitation must eventually move beyond the clinic into real-life environments, walking, traffic, escalators, supermarkets, and crowded space. These are not merely provocative situations. They are the environments in which the vestibular system must learn to sustain, reweight, and extinguish motion appropriately. If rehabilitation is truly addressing the temporal phenotype, improvement should be visible at several levels. First, symptoms should improve. Second, function should improve. Third, we may also expect changes in physiology. Responses may become more symmetric, more appropriately sustained, or more appropriately decaying, depending on the original phenotype. And finally, behavior should improve. The patient should recover more quickly after provocative environments such as supermarkets, traffic, escalator, or prolonged passive motion. This is an important point. Outcome measure should match the temporal complaint. This framework is clinically useful, but it is still a framework that requires prospective validation. Several important questions remain open. First, which laboratory metric best captures pathological persistence or insufficient storage? Second, do ocular and perceptual time constant always move together, or can they dissociate in some patients? Third, can we reliably distinguish excessive storage from a true failure of disengagement after motion has ended? And finally, are these candidate biomarkers reproducible across different centers, protocols, and devices? Let me close with 5 take-home messages. The first one is vestibular function is temporally organized. Different tests interrogate different operating regime of the same vestibular system. Second, a normal V-hit does not exclude dysfunction in the sustained domain. Third, velocity storage is more than a longer time constant. It integrates duration, visual information, and gravity into a central estimate of motion. Fourth, vestibular memory can fail in 2 opposite directions. The motion estimate may decay too early, as in the low storage phenotype shown today, or it may persist for too long and outlive the event that generated. And fifth, last but not least, both testing and rehabilitation should match the temporal phenotype. We should not ask only whether the vestibular system responds. We should ask how long the response is maintained, how it's integrated, and whether it's appropriately extinguishes. And this brings me to the final idea. I would like to leave you with vestibular memory becomes pathological when the duration of motion estimate is wrong. As I said, in some patients, it decays too early. In other patients, it long-lasting after the stimulus is ended. So, clinical vestibular testing should ask not only whether motion is detected, it should also ask how long that motion is stored, how it's integrated with vision, gravity, and how appropriately it is extinguished. This is the central message of the entire presentation. The fast pathway protects the image. The sustained pathway protects the patient. And between those two pathways lies the temporal organization of vestibular function. From the moving eye to the unstable patient. This is the velocity storage that returns to the clinic. Duration of the motion. And now we have reached the end of this journey, and this journey began far from the clinic, began in a habit. And now I would like to open the discussion with 4 practical questions. First, is the velocity storage truly measurable in routine clinical practice? Second question, which tests best reveal failure or motion disengagement? Is it the post-rotatory decay? It is the optokinetic after nystagmus is the perceptual measure. Third, where do PPPD or Marder-Bachmann syndrome and post-neuritis phenotype overlap? And where must they remain separate? And fourth, can rehabilitation be tailored to the specific temporal phenotype? These are still open questions, but they are also the questions that can move velocity storage from a physiological model toward a more precise clinical tool. The conceptual and clinical framework presented today is developed in 2 recent publications the 2026 narrative review of the velocity storage integrator, in our 2026 case series on persistent dizziness and time domain dissociation. Thank the organizer, thank Gerard, thank Mo, thank to Eugen, and by discussion whether routine vestibular testing should include explicit sustained domain and temporal metrics. Thank you very much.
And thank you, Leonardo. I thought that was awesome. That was probably the best discussion of this velocity storage I've ever heard. Are there any questions from the audience? Mohamed, I see there's a question on your face there. You got to unmute yourself, Mohamed. Mohamed, you got to unmute yourself. I'm not very good at reading lips.
Got it. All right. Let me back up here. Leonardo, this is beautiful and really reflects the difficulties of dealing with dizzy patients. Let's put it this way.
Amen.
And certainly all the questions you're asking are incredibly important. Until today, I try to actually look at the math of Robinson regarding the leaky integrator. I think the concept of leaky integrator is an engineering, truly engineering phenomenon, but trying to really apply it to the physiology of the vestibular system through equations is very hard. I still try to figure out all the equations that he put on his papers with everybody else, obviously. Bertau and, Ted Refan and Bernie Cowan left us more questions that they answered. I actually, if I may have a little extra time, I have a patient with a really very interesting presentation that I saw recently. That patient used to be a cyclist and for whatever reason stopped for a long period of time. And when he started to go back to cycling, his question to me was, I'm not able to go back to where I was. And it's fascinating. And I think this kind of vestibular memory impacts that kind of patients. So it's wonderful. I think we need another, if I may propose, Jerry, another session where we dig deep into the questions asked and try to at least express some points of view. But thank you again, Leonardo, for that. It's a great talk.
Yeah, I agree, Mo. I think each of Leonardo's questions we could spend a whole hour on.
Yes.
Yes, 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 yes. It is just a start to understand this revolutionary way to see the patient. That, in any case, is very simple. We are just recording tests that we have in our laboratory, tests that we lost because we need to try to make the things very simple. But the vestibular system is not so simple. It's not so simple. The vestibular system is very, very complicated and is very fascinating because this story of the motorway and the road is absolutely incredible. Really, it's a really true story for every patient. Every patient, yes. Producing a patient with the VHIT test, oh yes, you are crazy, you are anxious. It's not a good way to understand what the patient are having. Yes.
So, Leonardo, question. Who should really be seeing dizzy patients? ENT, neurology, otology, neurotology. I mean that this is I'm not being funny here. I think this is a very critical question. What are your
Yeah.
views about
It
it?
is a very crucial question. Here in Italy, we have a big problem with neurologists because neurologists does not perform nothing about what I'm saying. In Italy, we only ENT doctors perform this type of investigation. And I think that otoneurology and vestibular medicine must have it must have a new story that must begin from this crucial question. Vestibular medicine is totally different from ENT and the neurology practice because it reveals a huge, tremendous planet of investigation, of thinking, of reasoning, that it's totally different from neurology and ENT.
Well,
Yeah.
it's an orphan subspecialty, as I always said. Actually.
Yeah.
Really is.
Leonardo, we have a question from Sachu, and I apologize if I'm mispronouncing the name. Hi, sir. You propose that abnormalities in velocity storage underlie several clinical phenotypes such as persistent dizziness, PPD symptoms, visual dependence, and low storage phenotypes. But what main clinical evidence demonstrates that velocity storage abnormalities independently predict these symptoms beyond the vestibular test you do daily? Or how do we know velocity storage is causative rather than simply associated physiologic findings?
Yes. This is a very important question, and this is what I ask to myself every day. At the moment, it's practically impossible to say if the problem starts from the periphery or from the central. Probably is a mixed problem. Because into the cerebellum we have a selected population of neurons that are activated from the periphery. And this is the beautiful story of Kathleen Cullen lab and huge literature. And we must return to understand where is the problem before. I think that probably periphery starts, then periphery recover, but the central is missing to understand what the transmission says, the new transmission says. So the problem is there, the transmission from periphery to the central. And of course, there is another huge chapter of the story. Many contributions come from visual, posture, proprioception, something and some other system, and we must learn many other things. But this is, I think that this is the right start to understand many problems of our patient.
Bulent, did you have a question?
No, I just want to know the experiments we're doing. So with the students too. I was gonna show you the optokinetic after nystagmus that we were observing if you're interested, but you need to give me the option to. I need to take the. I need to show you my screen, so I don't.
Go ahead. Ask for permission.
Yeah.
There you go.
It's background. Right. Share. Yep. There's a share there. And share. Can you see?
Yep.
Yeah.
Hold on. Let's see.
Oh, wait, that's
No,
more.
I need to. Can you see?
Yes.
Can you see? So we're doing some after optokinetic after nystagmus with the students. I just want to show you this one. So we are very primitive. Sorry, we're just using the and there, and then she's gonna stop, and we'll close it. Right there, you see the pupil get bigger. Yeah, so I just wanted to show that to you guys. Yeah, I can show you one more time. You're doing that. It's probably we calculated as a 20 on the regular millisecond, and now he's gonna close it. Still try to find. You see that eye is trying to still looking for that thing. So anyway, I wanted to share with you guys.
Was that's a student that's being tested?
Yeah, we're doing that. We're doing this with the students. We're continuing our velocity storage vibration thing.
Is it a hazing ritual for your department?
Huh?
I'm just joking. Is it a hazing ritual for your department? Just kidding.
We do all of them to figure out in there. So, I mean, I have a question to you, Leonardo. We are very interested on this. So we presented with the student on the late phase of this caloric response. We have this subjects to sit and vibrate their skulls, and when we are first doing it, I just asked to AI and all the other things what kind of a response we should get with the vibration, before when we're writing the protocol for IRB. It all says that, the nystagmus, when we do that, should be going to the opposite way based on Kurtor's Ein's papers. And then when we start doing that, we see the nystagmus on the wrong direction. And it's constantly doing this. Why is that doing this? We think that it's again has to be explained with the velocity storage. But can you give us a quick something on there? Why in the middle of towards the end of the caloric testing, when we vibrate those skulls, instead of seeing the nystagmus opposite way, we see it towards us, towards the caloric ear, and the cold caloric we're using, by the way.
Thank you. Now, when you vibrate the head, you're stimulating both sides. The caloric test looks at one side only. So that might explain the discrepancy of expected post-vibration upness of
Yeah, but we do the head shake, but we don't see the same thing. We shake their head.
What frequency?
We don't see it on those. We don't see anything in there. The only explanation we get is in the certain time frame on the caloric when the has been weaning off. We see this response. And then after this caloric completely resolves after 10 minutes, we don't see this response anymore. But during that time, we see that response.
Extraordinary, thank you, because I think that when which type of frequency you use with your vibration?
Which type of vibration?
Frequency, 100 or 30, 15 hertz?
100, 120.
120, okay.
Yeah.
The problem is vibration, and we think now at in this particular 2026, we now are thinking that vibration is phase locked. But you are right, you are not wrong, because probably vibration exploring a very selective new type of neurons.
Oh.
This new type of neurons is the dimorphic one. And the dimorphic one is very sensitive to calorics, and because they are connected with the type 2 cell and the type 1, And for this reason, you can see a very different results after 10 minutes just after the caloric stimulation. This is my idea, and I'm publish this idea in the next days, probably an hypothesis, but I see the same thing in Cassino. I see the same things. Thank you, because it's very, very tremendous new way to understand what happens with this test.
Awesome.
And we think about what happened with superior semicircular canal dehiscence. When you use vibrator-induced nystagmus in this type of patient, you can see an after nystagmus. Why the after nystagmus? Probably there is an explanation from Dumas and Courtois, but think about the dimorphic one. There is very poor literature about dimorphic. We are simplifying vestibular system for decades. Regular versus irregular, but they are very poor population, regular versus irregular. The most prevalent population of neurons are irregular, are the dimorphic one.
The way that we thinking at this point is, well, thank you for the information that it could be from a different neurons. What we are thinking more is when we do caloric on these patients, we create a temporary, disease-like stage. So we confusing like the ones that you put on the slide, like a disappropriate on that part. And that's why we open a window or a gate on that part. And then we see this. And then a few minutes later, rest of the brain picks up and then comes back. It's the same thing. We see it on some mastoidectomy patients. You remember on seeing those cavity patients? There's nothing in there. And then, but you put a tiny little suction there. Oh my God, they start immediately have a nystagmus. And then you have them sit up, it stops immediately. So for some reason, that tiny little thing can be felt in certain times, but not normally, not in many times in the others. Anyway, well, that was a good talk. Thank you. And I will, although in and out, I was supposed to see patients, but I will look at it again. That's a good talk. Thank you.
Yeah.
What do you think? Our explanation.
A testimony to how good the talk was. Absolutely.
Yeah.
Are there any other questions before we close out for the day?
Close for the day. Okay. I'm leaving anyway.
Yes,
Sorry.
thank you.
Bye-bye.
All right, guys. Well, we don't have a date for next month, but I'm going to be presenting a case of oscillopsia and poor balance. So stay tuned, and we'll send out an invitation to you guys. Leonardo, thank you so much for your presentation. I hope to entice you to join us every month.
Thank you.
Yeah.
Thank you very much.
Thank you, Leonardo. That was great.
Yeah, really good.
Gary,
Really enjoyed it.
Gary, Leonardo.
Oh, Eugen. Yeah.
I don't know if Leonardo is gone already.
No, I'm here.
I would like to salute you, to congratulate for your presentation, extraordinary, where I am very happy because, of course, we have no conclusions, all the conclusions, but at least, and I'm happy because now 2 or I don't know 3 edition before of this discussions, we evoked the fact that in many clinics which perform vestibular assessment, they perform VHT, the video head impulse test, on head impulse test, on maybe some VNS to look to an nystagmus, but that's all. They didn't perform neither caloric test, neither rotatory test, etc. So I am very glad that the discussion is very complex, of course, and it was excellent. Thank you very much. And I must say you that you had another listener very interested was my wife, because I'm in car and I'm near to Lyon now, and she's a neurologist. And I think that there are some neurologists now that start to understand vertigo.
Oh, great.
So
Yeah.
thank you very much, Leonardo. Thank you all.
Thank you. Thank you, dear friend. Thank you.
Thank you, guys. Y'all take care. See you next month.
Thanks,
See you.
Jerry.
Bye-bye.
Take care.